Welcome to Horton Implants Oral Bites with your hosts, Kate Bootman, Will Murphy, and Carl Horton.
2 up for hats.
No hat.
And wigs.
No.
And wigs.
Good evening, everybody. Welcome back on this Friday evening. Hope you've had a good week and you're looking forward to a very, very hot and sweaty weekend. You'll see that I am joined by the devilish duo in the form of Will Murphy, and we have Carl Horton. Good evening, gentlemen.
Good evening.
We're absolutely thrilled to say that we're joined by Simran from EVO Dental. Good evening.
Oh yeah, thanks for having me on.
No problem. It's going to be our pleasure. Our pleasure. Right, boys, come on. I want you to indulge us. Carl Horton, you can start us off. How's your week been?
Short and sweet, really. It's been COVID central at my son's school. So unfortunately, he's now going to miss the last few days of school because they're self-isolating, dropping like flies. Today, just chatting off air with Simran. It's been quite an interesting day. Thankfully, a nice, straightforward sinus lift with a fairly few straightforward implants. So that was nice at Liberty Place. Malvern the day before that, so still doing the travelling around. Again, 2 great clinics, excellent support. Something on the online stuff, building up the courses, and it's been a real thirsty day, so I have to take a little sip of this. Will, you watching anything?
Oh. Is that the absinthe? Oh, get lost. Seriously.
Yeah. Very refreshing.
Good man, Carl Horton.
Horton vodka.
Gets us through the day.
They do this alcohol-free gin, which tastes just like gin.
Oh, yeah.
But
they can't call it gin, can they? They have to call it something else. Because you can't say gin you can't have alcohol-free gin, apparently.
Oh, okay.
There you go.
Everybody. Yeah, thank you.
It's not just teeth you get on here, is it?
No. And yeah, just nice and straightforward. A lot of planning. I mean, so we've had a few little issues with a couple of the bits on the planning side, just because we use some software that we have to upload, and we use a company where they email it to us, and just struggled sometimes getting that. So that's been my pain of the week, and hopefully we've managed to resolve that with a few little sort of what I don't know what you call it really. I don't know what you put. Protocols, shall we say? Put some protocols into place, so hopefully that won't cause us any niggles. That's been it. But I know there's somebody that we're going to talk to that's got some amazing protocols, which I think just blew me away when I saw how smooth they were. But anyway, that's been my week.
Your week, good man. You've survived. That's a good sign. So, Will Murphy, what about yourself?
Very nice week. Started off with a nice weekend in the Cotswolds last weekend.
Very good.
Didn't quite go to plan, because the whole idea was to stay at this sort of nice Cotswoldy pub restaurant, which is pretty well renowned for the food and the restaurant. However, when we got there, it sort of appeared it was all very quiet, and so we were booked into a sort of sister restaurant for the first night, and that was fine. And then the second day, I worked out something wasn't quite right, really, because there seemed to be nobody in the kitchen. And then it transpired that the chefs had all had to isolate. So they were keeping it under wraps a little bit. And all of a sudden they were kind of like, but we can do you a pizza. You're like, let me think. So there was a little van in the car park sort of firing at pizzas, which looked very nice, but I guess that wasn't really the whole reason for going. So I did a little bit of passive-aggressive customer relations work, and our money was refunded, and we headed home and had a nice takeaway.
Oh,
so yeah, maybe another time, but it was great. Yeah. It was good fun. We actually we thought we'd drive past Jeremy Clarkson's farm, because he's in the area, and he's got his little shop. Yeah, so the Diddley Squat Farm shop. So we drove past, and there was a queue like about a mile long for this tiny little shack that just sells a bit of tat. So we thought, forget that. Turned around, headed for home. Dentistry wise, just running around from Birmingham to Norwich to Hertfordshire. Everything's gone pretty smoothly this week. I've got no tales of woe to report.
Fantastic.
All the implants are in the right place. In terms of planning, I use a sort of pen and a bit of paper. So
nothing wrong with that, Will.
I tend not to have those glitches unless like the nib breaks off the pencil. But that can be resolved. So apart from that, everything's run pretty smoothly. There you go.
Brilliant.
That's fantastic. That's what I like to hear. Has it been one of those cheeky 4-day weeks for you?
No, I'm afraid I've done the full 5 days. I know someone's got to do it. Yeah, there you go. We'll get over it.
Oh, fantastic. Well, boys, I'm glad to see you've survived your week. And as I say, Simran, we're really, really pleased you've joined us. Now, obviously, we know a little bit about yourself and where you work with EVO Dental. Can we ask you to tell those out there who don't know what EVO Dental is?
Yeah, so we're a clinic that focuses our sort of work on just full jaw implant rehabilitation. So rather than sort of doing sectional singles and that sort of work, we tend to we just treat patients who are sort of terminally dentate or edentulous, and we just do full jaw implant rehabilitations.
Okay, and Carl was Will, you spoke about it when you came back from the EVO experience, but the processes are absolutely amazing.
I think you're underselling it here. If I'm going to be honest.
I think certainly the practice itself, I think, started around 2007 up in Liverpool, and originally it was sort of just it was an implant practice, and I think over the years it's morphed into what it is today, and I think that's where the sort of evolution name comes from. EVO Dental is over the years, it's morphed into just focusing on that one line of work, and I think it's got its benefits of being sort of focused in one area. You can really specialize the whole sort of setup, even the sort of the clinic, to just that one treatment, rather than having to cater for everything else. So
who's behind it, and what's your role in the whole thing?
So the company is it was founded by a chap called VJ, and my role in the company is, so I'm the senior clinician in our Solihull clinic. We have 3 clinics, one in Liverpool, one in Heathrow, and now one in Solihull, which we opened, I would say, late May. It feels like years, but I think it's only been about 6 weeks. I've been with the company for, I think I joined 2019, and I've been up in Liverpool working with Isabella, who I think you may have met, and then since we've opened our Solihull clinic, I've sort of migrated down here. So I'm still looking for somewhere to live, but we're getting there.
Oh, Solihull is a pretty nice place to live. Can't argue with that. So, what's your background in implants? Where did you get into it all?
So, bit of a long-winded story, I guess. I qualified in 2016, and then I joined a practice over in Lincolnshire, and I had a patient come in with a lower all-on-4 and a couple of implants, and sort of being a couple of months out of uni, she was like, how's it looking? Is it looking good? And I was thinking to myself, I know what this is, but I don't know how healthy it is and whatnot. So I thought to myself, this is something I really need to sort of look further into. So we had an implantologist in house. So I started spending a bit of time with him, and I thought just watching him do placements and follow-ups and things, and then I was just watching, thinking, it's how hard can it be? You make a hole, put a screw in it, So it's pretty straightforward. Great. It's actually Sam Mohammed, and he does a course with Mukesh and Azhar. So I thought to myself, well, if he's local, easy to get a mentor, I'll do his course. So I did his course in 2018, and yeah, I did his course, and it was great, really good experience. Learned a lot, and then a job came up for an intern position at Liverpool, I think just as I was finishing, and I was, really excited. I was just finished my course. I thought, this is what I want to do, and the opportunity came up. I'd actually met VJ on one of the social events after some of the lectures, and he told us all about it, what it's like and what happens. So I thought, it sounds like the place to be if you want to sort of develop that side of your clinical skills. And I applied for the job, and I think maybe I got it because I'd met VJ. I don't know, but and then I started in 2019 with Isabella, and that's where most of my surgical training has been. We have a sort of an internal training pathway, and she's taken me, like I say, from someone who's got very little experience placing implants to doing, what would it be? Initially, I was doing probably in Liverpool 4 arches a week, up to now doing probably 8 to 10.
So that's a pretty rapid turnaround, isn't it? So I mean, but I guess in terms of years and months, your experience, I suppose, is it's been pretty rapid and a quick learning curve, I'd imagine. I mean, even now on these full arch cases, sometimes what you've planned and what you go in to put your implants into can be wildly different. Sort of, how do you sort of cope with that? Is it having somebody over your shoulder with more experience to bring in?
I think that was one of the factors that really drew me to going down that pathway with EVO was, it must be such an intimidating prospect to learn something like full arch implant rehab alone in practice with a mentor. There's so many different variables, so many things that you have to account for, so many things that can go wrong, and you need that support. So I think the great thing about being in EVO is it's the only thing we're doing. I've got great support. Isabella was always in the next room, and it was a very gradual process. Everything, even, to a certain extent, these sorts of cases can all be thought through as a process, and you can learn all the steps of the process. And because I'm not needing to deliver the whole thing, you can learn it in bite-sized chunks and then put it all together. And that was how we did it. And then we would internally sort of grade our cases, from easiest to most difficult. And you would then start with the easiest ones, and then slowly work your way up the ladder until you are sort of doing the most difficult cases. And just like you say, it's having somebody there whose experience can guide you through it before you go in, and even if you need them afterwards or during the surgery. So I think that was the just a safe clinical environment which is supported, and that was what helped.
How many?
Sorry, go on.
Sorry, go on, Will.
I was just going to say, do you set aside time for complications and management of issues? Because certainly in my hands, and I don't know, some of the papers you read, Papas Spiridakis, a sort of review of full arches, complication rates can be up to 25-30%, covering from biological to mechanical issues. So presuming, you'll be within those statistics, as I presume everyone is, do you set aside time for that sort of follow-up and management?
Yeah, I think, again, it kind of comes back to, because we're doing the one thing, the whole business is set up around obviously delivering that efficiently and managing everything that can sort of go on. I would say we always meet once a week. So we always meet once a week as a team. So we have a multidisciplinary team meeting with the technicians and clinicians. We're always reviewing the patients for the week ahead, all the prosthetic fits that we'll be doing the week ahead, and then any sort of cases where we have had any complications or unusual problems, and then we'll discuss them within a sort of team locally. So we'll have a meeting here in Solihull. They will be having one in Liverpool, and and one in London, and then also we can dial into the wider team. So I can dial in with Isabella in Liverpool, or Rudy down in clinical lead down in London. So there's a lot of support, and there's a lot of different I guess perspectives as well, which is quite nice. And then, you know, I think because we're working just on the one type of case or with the one treatment modality, we can I guess build that into the business. You know, we're vertically integrated. We have all the manufacturing and design is done on site. So prosthetically, we can manage everything, and we can have direct input into it. And then the same sort of, you know, surgically, we've got that capacity to manage those complications.
And how many clinicians do you have in the Solihull clinic, Simran?
At the moment, it's just two of us. So there's myself and Maria. So Maria is now sort of starting out her journey as an intern, and I get to give her the journey I've been through the last 3 years. And yeah, it's good. We'll have another one joining us about September time. So
okay,
it's not weird,
fantastic.
No, I mean, you hit on something there, and just to expand on it, it's something that both you and Will were just talking about. And when, I mean, you do these experience days, which maybe we can talk a little bit more about in some detail in a moment. But when I went up to Liverpool, you weren't up and running at this point, and got to see how everything was there. I think that team approach was fantastic, and the way that there was one of the mentees that's just learning there as well, and the way the whole team were involved on the cases, from everybody from the technicians to the clinicians, and the planning of the whole case, that was something that Will was touching on there, and the support that you all have, and the way that you all chip in and talk about that, the complicated cases, and the network that you've got. I think that adds to that training pathway, because I think from if you didn't understand what happens within EVO and the way that everything is organized, I think somebody might think, well, that's a rapid pathway for somebody to be in your position. But actually, when you see how it actually works, and the fact that you just focused on this treatment modality, and actually the support that you get, you know, I think it's fantastic. I think that the training pathway you have is superb.
Yeah, I think I don't know, like you say, I don't know how I would approach this if I was to do it alone in practice.
Yeah.
You know, I don't know how I would approach it. If you're doing, you know, 4 or 5 cases a year, you'd be having a mentor for a couple of years probably. You know, so I would feel that would be necessary for myself. And you know, I don't feel like it's something you can learn on a weekend. It really is total immersion, and it was just 5 days a week. If you're not working in surgery, you're working on the prosthetic side, which is, you know, equally important. And having that total immersion, I think as well, what I liked about being in Liverpool was I've got the whole historical patient base to look back at, you know, so I'm seeing all the patients from 10, 15 years ago coming back for their checkups, seeing, you know, what's in their box, what prosthetics have they had, how do things look after all these different prosthetics, and how do things look after all these years. And yeah, it's really good for just building up your knowledge base and finding out how to manage these patients.
Is there any academic sort of didactic learning on your pathway, or is it all just hands-on on the shop floor, as it were?
Yes, it's hands-on on the shop floor. I think certainly that's an area that we are going to be working on more of the academic side alongside what we're doing clinically. It's one of those which is it's a case of time, isn't it? You know, we have like I say, lots of data from all these cases, and it's just a case of collating it and starting to look.
So can I ask, Simran, with the patients that are coming through to your clinics, obviously they are having, as you say, the full arch work done. So, I mean, I know some of the answer to this, so really I'm just asking you to explain it to those out there. Not just everybody is suitable for this treatment, which we understand. So you guys have a triage system.
That's it, yeah. So we have We have a sort of a patient journey, and that starts with the triage system. In fact, we have an inquiry form on our website, and the patient will fill this out, and one of the questions will be, what do you think you need? Is it a single tooth or a few teeth or a whole mouth? And if they select single tooth or a few teeth, then they're automatically sort of put to one side. Only until recently we've started working on partnering up with clinicians, and now if they select those, it will show them a list of clinicians who are local to them, who are sort of partnering, or usually it's people who have been like yourself on experience days and thought, right, we can work together and help these people. But that's one way in which we're sort of filtering out who is and isn't suitable. Another is just our patient coordinators. So we get a very detailed triage. How many teeth do they have? What's their condition? What do they think of their dentition? Sometimes we'll get photos and OPGs as well. And a lot of the time, before you even met the patient, you have a good idea of, what category they fall into. The perio, is it dentures? Is it terminal restorative work? And then once they're sort of filtered out, I think we did an audit, and it's, I think, less than 10% of our consultations are not suitable for full arch, but that's because the patient coordinators have turned away, I think, about 70% of the inquiries. Once we then have them for their consultation, so we have a free full clinical assessment, CT scan, and then patient will get their treatment plan, usually the same day or the next day, and then sort of take it from there.
I mean, that's the key, isn't it? Having efficiency of the system. Yeah. I mean, to me, it's like a luxury that I'll probably never have, in terms of having people to see the patients before I get near them, because obviously I'd probably have a lot more conversations with people who are completely unsuitable, that, we have to go through the little dance of saying goodbye or moving them on to different areas. What I was wondering is that obviously a lot of people are coming up with terminal dentitions, and quite often that can be periodontally related. And obviously, as we know, the bugs that have caused the periodontal disease, or the host responses, are still going to be there in full arch implant cases. They don't just go away. What sort of follow-up and maintenance, and how do you kind of get that across to the patient that, we're all sort of married to our implant patients in some respects, aren't we? How's that side of things managed?
I think, certainly my approach is, I think you have to be very matter of fact. I'm not there to sell anything. I really spend most of the consultation determining, are you suitable, and, what approach we would take, and then telling them pretty much all the ifs and buts. And certainly patients like that, I think a lot of them have reached a point where it's almost too much to manage their dentition. Grade 3 mobile teeth, it's very difficult for them to manage it. But you give them a fresh start, and you give them so what we do at our definitive bridge fits are, we give them a water pick, electric toothbrush, single tufted brushes. We design the prosthetics in a way that's cleansable. If it needs to be off the tissue, we will do that.
And obviously, there's an issue with patient motivation, because sometimes these patients have arrived at that point by having a water pick in the cupboard. That's my thing. It's just kind of, how do you keep them in the loop, as it were? How do you change their habits, which have possibly not been very good for so long, to become really good habits to look after the nice devices that are getting put in place by you guys?
Yeah, it is something that, like you say, you have to, you're very clear with them up front, what it takes to do it. And then we do see them, we see patients depending on their risk profile, either we can determine, I can see somebody as often as I like, but, every 3, 6, 9 or 12 months, depending on that risk profile. And then as well, it's just mitigating all those risks. The only thing you can't really control is the patient. But you make an assessment. We do as part of the triage as well, we do something called an oral health impact profile. It's got OHIP score, and it's sort of a questionnaire which determines how their dentition is affecting their quality of life based on, psychologically, mechanically, so all these little factors, and even aesthetically, so you can sort of determine what are people's motivators, what have they struggled with, and all you can do is make your best judgment call. I think, in my experience, patients tend to be motivated after a fresh start. Not everybody, but the vast majority do. I think a lot of those who come with, like you say, a full mouth of grade 3 mobile teeth, they've given up maybe a couple of years ago, and then just kept their head in the sand and thought, you know what, I don't want to lose them. But when you give them that, okay, there is a way forward, you give them the bots, and a lot of them, I would say the vast majority, given a fresh start, tend to take it seriously.
So do they go on a maintenance hygiene plan?
Yes. Yeah. So they'll go on a maintenance plan, they say, based on their risk profile, which will be, what was their pre-op situation, and medical factors, things like dexterity, age, all these things. We have a scoring system, and then from that we will then put them on a recall, depending on what their risk is.
So have you got is there a hygienist in EVO?
So all the clinicians do it. So we don't have therapists, but we do it ourselves. So we'll have, I guess that was part of my initial training. I was doing some, but I think it's quite a good. It's good just in terms of handling prosthetics. Taking them off, you're cleaning them, you're optimizing the fitting surface. Looking, can the soft tissue be improved in any way? All these sorts of things you're looking at, and yeah, it's the clinical team who actually manage it, the dentists rather than therapists.
And lab-wise, Simran, how many lab techs do you have in Solihull?
At the moment, we've got 3. So we have a digital technician, and an analog technician, and then another who kind of does everything. But I think really everybody does everything. But yeah, our lab sort of we have milling machines, so we mill our prosthetics on the day. We mill them to the implant interface, so directly, and we have a team that, so usually I'll finish surgery, sit in with the digital tech, review the design, and then we'll finalize that together. Now we've got the implant locations, and then we'll send that through to mill it, and then the analog tech will finalize that. And then even just for, I think it's great for, and this is something I'd miss in practice, is just for maintenances. So recalls, you can always take it into the lab, again, optimize the fitting surface if you need to, or reline it if you need to, or manage repairs and things like that. It's all just very easy to just wander into the next room, get it dealt with, and then patient on their way.
Yeah, they must be busy people.
Do you do any sort of pre-op planning? Do the technicians kind of plan things pre-op at all? So do they kind of have the scan, the CBCT, and have a look at the sort of superstructure and maybe plan that before the patient comes in? And is there any of that, or is it just Yeah. So what we'll do is we'll that's part of our multidisciplinary team meeting. So we'll have the data from the clinical assessment. We'll then, I'll usually just record a short video of my thoughts about, the patient, the general idea for the prosthetic plan. We'll then at the meetings we'll get those up. We'll watch the videos and then start. It's quite nice because it's everybody mucks in. There's not I'm the boss. I say how it goes. Everybody mucks in. Everybody's opinions heard, and then we kind of do what we think is best for that patient. So we have a general plan, and then we get it all up. We look at all the data, and we finalize that. But then, let's say the nature of surgery is you will see something during surgery, or you will place your implants in a certain way based on, what happens during the surgery. And it's good to be able to make those tweaks afterwards as well. Yeah. I was going to say, because the design element can sometimes take quite a bit of time. Yeah. So I'm thinking if you just suddenly gave the the technician the scan or the cast, depending. I think you guys are scanning. You can probably tell me a little bit more about that in a little bit, because when I was up at Liverpool, they were still using the plaster Paris. But I thought if you give that to the technician's then got to design everything. That's quite a lot of work to be able to get that designed and then get that onto the machines and milled and then everything put into place and then fitted, because you're probably quite rapid within the surgery because you just basically, you know what you're doing. You pre-planned it, you know where you're going to be putting the implants within reason. If the bone behaves itself, you're quite quick. But those technicians, that takes quite a lot of time for them to be able to plan that prosthesis from the scan they have and then get it onto the machines again. It takes certainly a lot longer than you probably take to put the implants in and close everything up.
That's it. I think with us having sort of a pre-op set, I guess you call it a wax up, wouldn't you? But a digital one, pre-op digital wax already, and most of the time, I would say, we do our surgery. It's in the right prosthetic envelope, the placements, and we're sort of where we want to be with the wax up. All we're really doing is looking at it and saying, yes, let's go to the next stage, and turn that from a digital wax up to a physical set of teeth. But I would say 90% of that work is done, much long before the surgery, and then final few tweaks on the day based on whatever you see during surgery or things like that.
I was impressed.
So on average,
your technician was saying that they'll be able to mill the whole prosthesis in about an hour and a half or something, or they're heading towards that level of. I mean, that's rapid, isn't it?
Yeah.
That's very quick. Very quick. So on average, if a patient was seen by yourself today, when would they be looking at having the surgery?
I would say
tomorrow.
I don't know. I have to have the treatment coordinator.
Half an hour.
It would be, like you say, if it was that, they say treatment coordinator would get in touch with them, start the process. It would be then consultation, and then once they've had some time to digest that and the consent, we'd then follow up on the consultation. We do basically we call it a validation of the consent. We do that afterwards, and then that's probably let's say a week, 2 weeks before surgery, and then surgery. On the day of surgery, it's patient in at 9, patient out at 5:30 with fixed prosthetics, and then we will see them. We'll usually follow up just by telephone, so we'll call them 3 weeks later. Make sure there are no red flags, make sure everything's going okay. If we need to see them, we will. If not, we'll see them then at 6 weeks. We'll review them, check soft tissue healing, check sort of prosthetic positioning, because on the day of surgery usually they're a bit swollen and a bit sort of wonky. And then if everything looks good, 12 weeks we'll fit them with their definitive prosthetics, sign them off, and then it's on to maintenances. So it's a really sort of regimented process, and it's like I say, all our processes are quite well developed, and then it just allows that efficiency to get everything done smoothly.
Flows nicely. Yeah. So I mean, if they had a consult 1 week, with availability wise, it could be likely that they'd be having surgery in 3 or 4 weeks' time.
Something like that, yeah.
And are many under sedation?
Yeah, I would say it's interesting on that. Historically, we've generally just used oral sedation, so temazepam, and I think probably about a year ago we started doing IV sedation. I don't know. I feel like IV sedation is more intense but shorter, and it's harder to keep them sort of, I would say, at a comfortable level throughout the procedure. Whereas the temazepam, it's not quite as intense, but I think the patient's generally more comfortable throughout the day, almost like it's sort of, slower digesting. I think ultimately, how I present it to patients is, the sedation isn't going to do this for you. And it's one of those where, if needs must, then they will know that, actually it's worth going through it, ends justify the means. And I think I find patients who rely on sedation have a harder time of it, if that makes sense. I don't know about your experience with this.
Yeah, probably very similar actually.
Depends on the patient for me.
Yeah. I tend to find generally they because they're more the apprehensive ones, they tend to have that kind of, I suppose, that bigger fear factor.
Yeah.
But yeah, I guess I don't do sedation personally. We can get somebody to come in and do the sedation for us. I just bore them with my voice. Really, that's what tends to send most people.
Tell them about your gardening.
Yeah. Let's not go there.
Let's not. Well,
yeah, just got some more compost tonight. So,
oh,
in terms of, I mean, a couple of things that, I mean, what you do have in Surrey Hill, because Will's obviously been to your clinic and seen that, was the ability to do the intraoral scanning. Now, is it the photogrammetry that you're using?
Yeah,
it's slightly different. So how does that? I mean, what we saw, or I saw up in Liverpool, was the plaster Paris taking that cast, and that gave really good accuracy. But you guys, I think you've gone digital. So what are you using on the digital stage? How does that differ?
Yeah, it's going from the plaster impression to photogrammetry. I mean, I would say plaster, having used it quite a while, is I think it's good. I think it's pretty predictable. I think the benefits really of going to photogrammetry are we can then go modelless. So we've not got hundreds and hundreds of boxes of patient models stored, but also it's even more accurate. So more accurate as well for us. I think as well during the procedure, it does make a big difference. Even just the scan flags are smaller than pickups. You've got a patient who's had their mouth open for a couple of hours, they're tired, and starting to not cooperate, and then you're going to load them up all the way back to the pterygoids with plaster. It's not a pleasant experience for them or myself. So I think all these little factors and just it sort of naturally fit into our workflow. So instead, you're just putting scan flags on, you're scanning with an extra oral camera, and within 15-20 seconds, you've got all the data you would get from a 3 or 4 minute plaster impression. And like you say, we're analysing it to see in terms of how does it compare in terms of accuracy and things. But I think looking at it, it's definitely improvement.
Well, that was going to be my next question. Really, is you're looking at the comparison between the two, because I'd be interested to see, because some people are a little bit wary of it when it comes to full arch. But I've got a colleague that swears by it. He does a lot of full arch, but he's using an intraoral scanner rather than the photogrammetry. And then the other thing was the final prosthesis. I mean, what I saw, I know it's sold as a functional appliance, but it's not just a functional appliance, is it? It's pretty aesthetic at the end of the day. So they do get some very nice looking teeth. And it's what you produce is pretty decent quality stuff, isn't it?
Yeah, I think like say we do it, or we kind of, our angle is a functional rehabilitation. I think just the aesthetics come as a side effect of doing it. Really, a lot of these patients, like say, either are missing a lot of teeth, or terminal perio, and it is a step forward regardless, if you know what I mean. But no, it's something that say we look at every single definitive at our multidisciplinary team meetings, and really look and try and get the best outcome for the patient. It's good to have that many eyes on it rather than just myself.
I think for me, the bit that impressed me was that full arch scanner, because again, when you've done it analog, the impression stage just comes at exactly the wrong time, doesn't it? Everybody's literally using the will to live.
It really makes a difference, I think, for the patient's comfort. It really does.
I bet. Well, gentlemen, do you have any more questions? Because unfortunately, we've reached that magical time of the evening. Have we lost
You turn your camera off, mate.
My connection seems low at the moment, and I've gone to audio mode.
Don't worry, mate.
Oh,
That's absolutely
don't
fine.
worry, don't worry. Well,
What you've done is you've actually beaten Will, because he's usually really rapid at.
I'm usually first one off.
Yeah.
fastest finger first.
You've really upset him. You've really upset him.
Trying to get to my first beer of the evening. So never mind. Second place is fine.
What we want to say is obviously a massive thank you. Even though we can't see you, we know that you can hear us. So a massive thank you, Simran.
Huge.
Honestly,
Massive.
What we are going to do is there'll be some details of how anybody out there can contact EVO Dental. So we'll put the details on there for you. Will Murphy, pleasure as always. Carl Horton, it's all right.
Yeah. When you say contact, we're going to put the stuff on for the EVO experience for dentistry.
Yes,
so that anybody that's sort of listening to this dental wise, and also patients that are interested. But the EVO experience, just to say that, the thing that Will and I have been on. So you get to go for the day. Don't be late like I was. But you get to go for the whole day and have a look at how EVO works it's like a tour around the inside of the Cadbury factory, but more, it's more interesting. And Simran, I mean, I've never known all three of us want to ask questions so intensely. I feel you've been put under a spotlight there, so I do appreciate it. Thank you very much.
Oh, thank you for having us. And anybody welcome to come spend a day with us and sort of watch a patient journey. Hopefully,
highly recommend it. Highly recommend it.
Right. Well, as we say, we'll definitely put the details on there so that they know who to contact.
Brilliant.
Gentlemen, in the meantime, have a fantastic weekend and
have a good one.
See you next week.
Thank you.
Yeah. Cheers.
Take care.
Bye-bye.
Bye.